to meet you all from all across the country, and I know around the world. I'm going to share my screen, and then we'll begin. All right. So I will be talking about research that has been done with my organization, STRIPE, Strategic Training Initiative for Prevention of Eating Disorders, Public Health Incubator, and then talking about our collaboration with the International Socioeconomic Laboratory, ISL, and our work recently on the legislative front, which Ryan mentioned to you briefly. I'm going to begin by talking about our research in the social and economic cost of eating disorders in the United States. And then I'm going to take a step back to talk about this as a case example of strategic science to advance policy action. In our case with eating disorders, but the techniques for strategic science and advancing policy action can be applied in any domain that you may be most interested in. I have no financial disclosures or conflicts of interest. So overview of my presentation would begin with a brief introduction to strategic science, and then that's something I'm going to come back to later after I walk you through our economic study of eating disorders and the key finding there for the impact of eating disorders on the United States. With that, I will step back to address the bigger picture of how this report, the economic report, is a case example for strategic science, and I'll walk through the rationale, the approach, and amplification and policy translation work. I'll wrap up with a few concluding thoughts around that work, and then as an epilogue, I'll talk to you a bit about the policy translation work that we're doing in partnership with ISL. So to begin, the idea of strategic science has been around for a while, but it's colleagues of mine, Dr. Kelly Brownell, who's the Dean of the Public Policy School at Duke, and Christina Roberto.
Hi, sorry to interrupt, but your screen's partially obstructed by like another window.
Oh, thank you for interrupting.
Yeah, sorry about that.
No, I appreciate that, interrupting. So is this better?
Yeah, that's good. Yeah.
I apologize for that. Thank you for interrupting. I appreciate you.
Would you be able to just make it a little bit more for full screen? I think we could only see a portion of it taking up your screen.
Okay. Yes. Thank you. Let me stop the screen share, and then I appreciate your stopping me. I was once giving a lecture in Japan, and I was trying to speak at a slower pace, but I was still speaking too fast. And I appreciated that people stopped me and had me change the pace of the way I was speaking. So I believe this time it should work better. Let's try this again. And I'll go to, now, is this not obstructed?
It works fine. Thank you so much.
And this is good. Okay, thank you. That's the kind of assertiveness we need to make sure all of this work gets done and that we're communicating clearly. So I appreciate that. Colleagues of mine, Kelly Brownell, Dean of Public Policy at Duke, and Christina Roberto at University of Pennsylvania. They introduced the idea more popularly in the Lancet several years ago of strategic science. They defined strategic science as research designed to address gaps in knowledge important to policy decisions derived from the reciprocal flow of information between researchers and policymakers. And I would just make one correction to that, or amendment, to include in that community advocates and experts by experience. And they go on to say that strategic science is communicated not only in scholarly publications, but also in forms relevant to policymakers. And again, a minor amendment to include community advocates and experts by experience. Just critical, absolutely critical to be involved in this work of strategic science. And you're going to see some examples of that in a little bit. So what I'd like to do now, just hold that thought about strategic science. I'm going to walk you through our economic study, the most comprehensive economic study of eating disorders in the United States, and then we'll come back to strategic science. So for this work, we collaborated with Deloitte Access Economics and with the Academy for Eating Disorders, which is a global professional society for eating disorders. Key takeaways from this report: eating disorders are common, they are deadly, and they are expensive. Nearly 30 million Americans alive today, or close to 9% of the US population, will have an eating disorder at some point during their lives, either in the past, present, future, some point in their lives. Nearly 2 million children alive today will have an eating disorder before they are 20 years old. Here are some of the key points from the study, and then I'm going to delve in more deeply to walk you through some of these costs. Eating disorders affect people from all groups, all corners of society, all communities, at all ages, starting as young as 5 and well over 80 years old, all race ethnicity groups. However, people of color with eating disorders are half as likely to receive a diagnosis or to receive treatment. And this has to do with breakdowns in our medical system where people are not getting the access they need to care. All genders are affected. We know that females are around 2 times more likely to have an eating disorder than males. Most of this research is with cisgender, females and males. We're starting to see more research showing higher rates in transgender and gender non-binary individuals also. So that's a growing area of research. All sexual orientation groups are affected. All body sizes are affected. We estimate that over 10,000 deaths per year result in the United States directly from an eating disorder. And that equates to 1 death every 52 minutes in this country directly attributable to an eating disorder. For our study, we use standard cost of illness modeling methods that have been used with many different kinds of conditions to estimate financial costs and reduction in well-being. We used what's called a 1-year prevalence method. So the estimates I give you are for a single year, the late 2018 and early 2019, the fiscal year spanning that period, 1 year, 12 months. And note that this is before the pandemic. We know that eating disorders have gotten far worse during the pandemic. This study was completed just before the pandemic. We've started by going through the epidemiologic literature to get what's the latest data on prevalence, on mortality, on quality of life, which is critical for estimating well-being losses. We looked at the economic burden in 5 payer groups. That's individuals, families and carers, government, society, and employers. And then we went through the steps of cost of illness modeling to estimate costs for health systems, that's hospitalization, emergency department, primary care, outpatient, residential treatment, anything that's part of the health system. We also looked at productivity costs and businesses. Okay, we got that recording down. No problem. We got, for productivity costs, we're looking at absences from work, reduced workforce participation, reduced productivity at work, premature mortality, and then caregiving. And this, all of this information we combine with information about years of healthy life lost due to other illnesses or the consequences of an eating disorder, and years of life lost due to premature death. Some of the key findings around costs here on this slide, and I'll walk through these in more detail momentarily. We are estimating that close to $65 billion per year are lost in the US economy directly attributable to eating disorders. And this $65 billion each year can be broken down into several main categories. Productivity losses, again, this has to do with work, workplaces, close to $49 billion lost because of the impact of eating disorders and the lack of care that we need for eating disorders. Informal care refers to family members, loved ones needing to care for someone with an eating disorder. Health system costs at $4.5 billion we're seeing because of eating disorders. Now, well-being is a concept that through these kinds of cost of illness analyses, the concept of well-being tries to get more at the quality of life and how that's impacted by an illness. And the economists have come up with ways to monetize that. If you're not an economist or used to these methods, it can sound rather crass, but it is a commonly used metric quantifying in a monetary way the impact on quality of life. And the estimate there for eating disorders is well over $300 billion per year. Now, I'm going to walk through a couple of other costs here, and then we'll go into a little more depth. Cost to hospital systems. We're estimating close to 54,000 emergency room visits, or close to $30 million in costs for that, for emergency room visits. close to 24,000 inpatient hospitalizations, and that's totaling well over $200 million. Now, if you look to the right side, lower right side, you'll see losses per group estimated. Over $23 billion as the tab picked up by individuals and families each year because of an eating disorder. Government and employers are not far behind, with close to 18 billion, employers at over 16 billion, and then other costs to society over 7 billion. These are big figures here, and I'll do some comparisons a little bit later. So the next set of slides, I'm going to offer a little more detail about these costs, and then we'll be stepping back to think about how does this report fit into the big picture. With eating disorders in a single year, the prevalence estimate is 5.5 million Americans with an active eating disorder in the year that we're doing the analysis. So that's a lot of people actively with an eating disorder. We'll notice here with the red circle, you'll see the breakdown of different eating disorders. Most people are familiar with anorexia nervosa, bulimia nervosa. Those are the ones most talked about in the media, but they are not the majority of cases. The vast majority of eating disorders are either binge eating disorder or a catch-all category called other specified feeding and eating disorder. Terrible name, and it is not any less serious. It's that people have a combination of symptoms, and that's how they end up in that. You can see the light blue part of the pie and the dark blue pie take up almost the whole amount here because they're so much more common. Another thing I want to point out here, you see the age across the x-axis there with a big spike over the teens, 20s, 30s, up until the 40s. Nearly half of people with eating disorders are under 30, and that is an active eating disorder under 30. 83% are of working age. So this is going to come back. We're going to see this again when I talk about productivity costs. Now, the financial costs of eating disorders are large and substantial reduction in well-being. The annual financial cost of eating disorders, as I mentioned, nearly $65 billion per year. This equated to nearly $12,000 per person, individual with an eating disorder. I want to call your attention to the lower left part of the screen. Financial costs for types of eating disorders. As I mentioned, people tend to have heard of anorexia nervosa, bulimia nervosa. They do take up about a third of the cost, but it's actually these much more common disorders, the binge eating disorder and other specified feeding or eating disorder, that is the combination of symptoms that's not any one other disorder. These make up the vast majority of costs. That's something that few policymakers are aware of, and that's over a third is in that so-called catch-all category. Health system costs. The majority are coming from primary care and outpatient care, where we have health systems cost is just one piece of the impact of this condition on the economy, with $4.5 billion or over 800 per person with an eating disorder. And here the light blue takes up the most, largest part of the pie. That's for primary care and outpatient, because people need to be interfacing with the medical or mental health system to get the care they need for recovery. And that's making up the largest portion there. Productivity costs. Now, a reminder, this has to do with workplace, people being able to work or not being able to work, either because of their own eating disorder or caring for a family member. The estimate on the productivity costs is nearly $49 billion out of the total of $65 billion, and that's in a single year, cost to the economy, or close to $9,000 per person in productivity losses. Now, with this, anorexia nervosa and bulimia nervosa are very serious conditions, and when people are actively experiencing these conditions, the estimate is they may be missing work for an additional over 27 days per year compared to someone who does not have these conditions. For the other eating disorders, not quite as debilitating, or people may miss an additional 4 days of work. Now, down at the bottom right of the screen, you'll see productivity costs of eating disorders. Those are fairly evenly spread out across individuals, employers, and government, each picking up around a third, give or take. Other financial costs, I mentioned informal care. That's the way economists refer to the care that family members or loved ones provide for a loved one who is struggling with an eating disorder. And it's a vital backup to where our health system often has dropped the ball in not offering the care that people need. We're estimating that in what's called informal care is coming out to about $6.5 billion per year for eating disorders. And I want to note here, some of that is time that's in addition to work, where on close to 6 full-time working weeks per year are devoted by caregivers to a loved one with an eating disorder. We want families to be involved, but we also want our healthcare system to be really helping them and picking up much more of the care than the health system is currently doing. I just have a couple more slides like this, and then we're going to take a step out. So who bears the cost? Total financial costs borne by individuals with eating disorders and their loved ones, we estimate at $23.5 billion. So this is out-of-pocket payments. This is over $23 billion out of people's pockets because the healthcare system has let them down and is not covering the full care that they need. Now, finally, with well-being costs, this is a concept that economists have developed for cost of illness kinds of studies to be able to make comparisons across communities, across countries, across conditions. Well-being costs with eating disorders are high, very high. Some of you may be familiar with the term disability adjusted life years. If you've heard it before, it's a very common metric used in the cost of illness studies and in economics. The estimate at 1.3 billion dailies or disability adjusted life years is what's been estimated for eating disorders. If you haven't studied dailies, just file that away. And at some point when you've had a chance to learn more about dailies and qualies, this will make a little bit more sense. But what is crystal clear is that eating disorders account for 1.2% of the total burden of disease in the United States. Eating disorders, which is something that few people are very educated about. Medical schools do not teach doctors about this. Nursing schools do not teach nurses about how to address it. And yet it's over 1% of the total burden of disease in the US is attributable each year to eating disorders. Loss of well-being, when monetized, we're putting the figure at $326+ billion per year, or nearly $60,000 per person. And that has to do with decrements or reductions in quality of life. Okay, now the comparison to other conditions that you probably be more familiar with. Parkinson's disease, very similar methods used by other researchers for cost of illness. Parkinson's disease, placing it at about $54 billion in 2019 in the US, attributable to Parkinson's disease, something that we clearly know is a very high public health priority, actually is coming up as less of a cost to the US economy than eating disorders. Schizophrenia, one of the most serious mental health conditions that we have. The ranges from multiple studies, somewhere between 27.6 billion per year and 111 billion per year in 2019 US dollars. You'll see that eating disorders at 65 billion comes right down in the middle of that range that we see for schizophrenia. There's several implications I want to highlight. This study, our study, is the most comprehensive study of eating disorders, the economic and social impact of eating disorders in the United States. This kind of research is critical for informing resource allocation, for research, for treatment, prevention. And this study, as the most comprehensive, really is giving us a leap forward in the field, in the country, and in health resources allocation to really fully understand the depth and breadth of impact of eating disorders. I'll highlight a few areas of research we need, and maybe some of you will end up leading some of this research down the road. We need more research looking at cost effectiveness of treatment and prevention options to reduce the cost of eating disorders in US society. Further research is needed to understand the additional costs with eating disorders that can be attributable to structural racism and other structural oppressions that keep people from getting the care they need, or may even be increasing their risk of developing an eating disorder in the first place. We need more research on cost effectiveness of different models of care, step care, integrated care models. There's a variety of models. Some are more efficient and more effective than others. We need more research on long-term impacts of eating disorders. Our study, as I mentioned right at the front, is focused on a single year. That's costs and social burden in a single year, but of course, over the lifetime, the consequences of an eating disorder can add up for a person. We need a lot more work on that. And one more area I want to highlight is a need to undertake research to estimate the costs that could be saved by preventing eating disorders through early intervention and early screening and identifying eating disorders before someone has had the condition for quite a long time. Okay, take a breath there. If I were in the room with you, I might ask to see if there's questions now, but I know with online, I should probably just keep moving forward. What I want to do now, we see a lot of numbers. All of those numbers are captured on our website at the report, and I'll show you how you can access the report in your spare time. You can look up the report and see the figures there, review some of this. I wanted to give you more of a sense of the impact of eating disorders, how it compares to other conditions, but I don't expect you to remember all those numbers. It's not necessary, but getting the sense of how serious they are is an important point. They are common, they're expensive, and they're deadly. If that's all you remember, that's what you need to know about eating disorders. You can always refer back to our report, free and available on our website. So now let's take a step back for the bigger picture. How does this report that we published last year fit into the bigger picture of policy change and generating evidence-based policy? So this economic impact report that I just walked you through in detail is a great case example, I would say, of strategic science to advance policy action, in this case for eating disorders. But one of the principles of strategic science that I will walk through now can be applied in any domain. So other issues that may be the important issues to you that you care about most, these principles could apply in that situation just as well. I'm going to walk you through the rationale for the report, the approach we use, amplification and policy translation, how we folded all of that into our work around the report. So the rationale. In the past decade, 3 major national eating disorders cost of illness reports have been released globally. From Australia, they were ahead of anyone else. Almost 10 years ago, and then 6 years ago, Australia's Butterfly Foundation, now this is a non-profit community organization in Australia, they contracted with Deloitte Access Economics, same company that we then worked with, to publish reports costing eating disorders for Australia. First report of its kind ever. And then in about 6 years ago, the UK, another community-based nonprofit organization, or charity as they call it over there, BEAT is the name of the organization. They contracted with Price Waterhouse to do a similar report just for the UK. Butterfly has gotten, that foundation has gotten the furthest, and they have had spectacular achievements in leveraging their reports and doing some subsequent strategically targeted surveys. So we're in Australia now, I'm talking about Australia. After publishing both of their cost of illness reports, first of the kind, they then contracted to do a survey of the experiences of people with eating disorders and their family members and how they lived that, the lack of coverage for healthcare in Australia, the barriers to care, the costs. How was that experienced personally by people with eating disorders? They did a very compelling report through a survey to describe that. And with that, and with very smartly targeted policy advocacy, they got over $10 million in funding toward treatment. In Australia, $10 million, $110 million goes much further than in the US. This was a major transformative change in health policy in Australia to vastly increase access to care for Australians with eating disorders. We saw that in the news several years ago, in 2018, and we thought, we got to follow their lead here in the US. They figured it out, we got to figure it out. It's never been done in the US, but we need to know the same kind of answers that they got in Australia. So what we did, and I'm talking, when I say we, I mean a partnership between my organization, Striped, and the Academy for Eating Disorders, which is the leading global professional society for eating disorders researchers and clinicians. So we contacted the same Deloitte Access Economics team who had worked with the Australian group and said, well, can you work with the US? do you know how to do this kind of work here? And they said, yeah, sure, we're very interested. So we set up a partnership, and then Striped had the funds to hire Deloitte to work with us in collaboration. Their team they do cost of illness studies all day, every day. This is what they specialize in. So they were uniquely suited to do this work with us. And one of the things we were trying to achieve, I'm going to flag this for you, is a cross-sector collaboration. This was not something coming just out of the ivory tower. We had Deloitte Access Economics, technical experts who were from the business sector, Striped, Academic Research Center based at Harvard School of Public Health. And then the Academy for Eating Disorders brought in the clinical perspective. It's the Global Professional Society for Eating Disorders clinicians. Now, with this cross-sector collaboration, we felt like we would be really well positioned to then eventually get our message out when we were done. And I'll come to that shortly. We put together an advisory panel of experts. Again, we wanted to have this advisory panel be cross-sector. As much as I love the ivory tower, I'm working at Harvard, been doing research here for a couple of decades. There's so much good work here, but our research cannot translate itself. We have to be working across sectors. And that's where with this team, we put together technical experts and experts with community experience. So our panel experts included academics like myself, community members, people from the business world, and people working closely with government. We also had panel members with expertise in health economics, in medicine, in policymaking, epidemiology, decision sciences, psychology, and experts by experience, which is, if you're not familiar with that term, it's a term commonly used by communities of folks who have experienced, whether it's a mental health condition or a physical health condition or something else happening in the world. They have a unique expertise of having lived what happens when this condition, when someone experiences this condition, or it could be about climate change or something else, but experts by experience have a unique voice. So now what I'm talking about now with the big picture is we got these findings, we had the report, we could publish them in an academic journal, but we didn't want to stop there. We wanted this work to be translated and communicated in a way that policymakers would be able to work with it and that it would get a large audience. So we've really focused on amplification. This is after all the technical work was done. We wanted to amplify the findings. And here's another important point: when you're working across sectors or across organizations, we wanted to have a unified voice. Because if you have a dozen different organizations, they might all have a different message, and then nothing really gets through. We wanted to coordinate a unified voice. So with the report release, we planned a press conference, and we timed it, the report release, with the International Conference on Eating Disorders. That was last June. This is the biggest conference in the field of eating disorders globally. We wanted the release to be there so everyone there would be aware of the report having been released. And we had a community member, community leader, and expert by experience moderate this. So normally an academic release of results of a study, everybody on the panel would be an academic, and everything would be communicated in a way that only academics who specialize in that field would understand. We didn't want to do that because it was all about figuring out how do we translate this. We had an expert by experience, Joanna Candell, moderate that session and help for our appeal outside of the ivory tower. We did Facebook Live interviews with a few different organizations, and the goal is to communicate with community advocates, who I'll get to this in a moment, critical for policy advocacy work, critical for being effective with policymakers, is to have community members. That's expert by experience, and constituents have to be involved. So we wanted to communicate with them in a way that it would resonate with their lived experience, and that they could make sure they can understand the key findings without having to be economists themselves. So part of the amplification effort, we coordinated with a dozen major eating disorders organizations in the US so that we could amplify in unison with a single shared infographic and shared social media. So on the bottom part of the screen, you'll see many organizations that are the major eating disorders organizations in the US. We collaborated with all of them. They all got on board with this unified voice because they all saw the value of the most comprehensive economic study for the US. we were able to do this with the key findings, and I'll show you a screenshot of the infographic in a moment. And this, as I mentioned, is to ensure that report findings would be integrated into their own communications, because we gave them the tools to do that with all the federal advocacy or state level advocacy that they do. So here's a shot of the one-pager infographic that we created. You saw little pieces of this earlier in my talk, and this is available for free on our website for anyone who wants this. It tells the story of our findings in a way that most anyone could understand. Educated lay readers, policymakers, scientists in other fields that they don't specialize in this. Everyone could understand the key findings here. One-page infographic had all the partner organizations' logos. It's something you'll know if you've been in collaborations and coalitions. Everyone wants to make sure they get their own visibility. And we created social media assets. So we had a week-long schedule. We gave them the social media assets to use to push out through Facebook, Instagram, Twitter. So we created all that. We didn't do it alone. We don't all go, we don't go to get our scientific training and then get all that too. We hired Capitol Hill based in Washington, D.C., government relations firm and a communications firm to help us do that. And a key opportunity they created for us is to get an op-ed place in The Hill. The Hill is the daily news source that's most widely read by federal policymakers. You may not have read it yet, but if you look it up, The Hill, every day they come out with op-eds and news stories about what's Washington doing. What are some of the federal issues? What's the new research that should be informing what's done in Congress or in the administration? We got an op-ed placed there last June. The goal was to get our key findings communicated in a way where the policymakers will be looking. That I mentioned, one of the ideas with strategic science is that we don't expect policymakers to read our academic journals. We will communicate in a way where they read about research and make sure it's accessible to them. Want to note, this was last June, a year ago. We had to use COVID as a hook. So we brought in a COVID angle, and then we're able to communicate our op-ed that way. Key findings and policy actions, we laid it out very clearly for policymakers. Begin systematic national surveillance of eating disorders. You know how the government will collect, we have lots of public health surveillance tools, as they call it, or surveys, collecting data on how many people are smoking or have they quit? Do they wear their seat belt? Are they eating fruits and vegetables? All these kinds of things the Centers for Disease Control and Prevention collects now. Well, they don't collect anything about eating disorders. Even though eating disorders are among the most deadly of any mental health condition, the CDC is not collecting data on eating disorders. We want that to change. Also, increase in research funding and correcting insurance gaps. I talked about how families are having to cover a lot of the gaps because the healthcare system is not providing the care. That some of that is due to gaps in insurance coverage, where eating disorders are just written out, that they won't be covered sometimes. It depends on the insurance plan. Part of our translation efforts is with policymakers and to get these meetings. So the government relations firm set up meetings for us. We worked with a firm called Center Road Solutions. We got meetings with National Institute of Mental Health, the U.S. Food and Drug Administration, the Department of Education, and more, CDC. Lots of meetings they set up so we could go in smaller group settings, answer their questions, share the results, talk about what they could do. This is all part of the proactive policy translation, research to policy translation process. We discuss our key findings, options for policy actions in these meetings, and we need the members of government that work at CDC or elsewhere to be part of these meetings, because they know better than we do on what of their programs could be changed, added, dropped, revised. They know better, but they need the original information and the motivation to do that. And this allowed us also to leverage the influence of other major non-eating disorders coalitions on Capitol Hill to help reinforce our message. So this is a team effort for sure. I'm going to give you a few concluding thoughts on bringing strategic science together with eating disorders, our eating disorders economic report and the research, and then I'll have an epilogue where I'll talk a little bit more about our collaboration with ISL. So a few concluding thoughts. We made critical steps forward toward more fully understanding the social and economic burden of eating disorders in the United States. In addition, these new data are allowing us now to estimate cost effectiveness, improve quality of life, and most importantly, lives to be saved through scaling up effective prevention and early detection and treatment. We were able to pull all of these key messages out through our comprehensive economic report. Now, from a strategic science perspective, our top priority for undertaking this impact report was to engage decision makers in U.S. government, in the healthcare sector and other sectors to motivate them to take action. So they had long said, oh, we don't have the data, we don't know anything about the cost. We gave them that, but we didn't just give them the cost, the economic results. We also built a whole strategy around the amplification, communication, working with community members and getting their stories out there. U.S. policymakers have the evidentiary base now. That's part of what strategic science does. Compelling evidence, $65 billion lost annually to the economy due to eating disorders. That's one life lost every 52 minutes. And the escalating mental health crisis during COVID-19 has just further worsened eating disorders. We're seeing doubling, tripling the number of people coming into hospitals across the country needing treatment for eating disorders. And that's due to all of the very tragic effects of this pandemic. Responsibility really for all of us. And I'm speaking to other scientists who work in eating disorders, or community advocates who work in this area, is to use these methods of strategic science to motivate policymakers to act. And we know the lives depending on us can't afford to wait. They can't wait the time it takes for academics to publish another 100 studies on this. What we need is for policymakers to be engaged and to act. So with that, I want to move to the epilogue about how do we try to get policymakers to act. They're busy. There's a lot of issues coming at them. Eating disorders is one, but there's many others. And we know that as state legislatures, they may have 1,000 or thousands of bills that are introduced in big states every year. That's a lot of competition for their attention. But we also know that it's only when researchers, community members can organize, work together across stakeholder groups, across sectors to get an audience with policymakers. That's how we move them. So I'm going to talk a little bit about our collaboration. We're policy translation in action right now. This is from the field right now. The collaboration between Striped, my program, and the International Socioeconomics Laboratory, or ISL. I talk about some of the work before we started collaborating with ISL in this article. There's a QR code. You could take a picture of that if you want, or we could share it later. It's an article, free access to the Harvard Public Health Review. Odds, Arcs, and Policy Change, a step-by-step look at our public health campaign on how we took on the issues. And specifically, it's about diet pills, which is one small facet of eating disorders. And then more recently, we started working with ISL, and it's really taken off since then. So I'll just give you a few words around these products. You may see them at any grocery store, in the corner store like a 7-Eleven. You'll see them sold in gyms, in GNC, and health food stores. They are over-the-counter products sold for weight loss, or shorthanded is diet pills, or the products sold for muscle building. I'm folding that in here because it also, the sale of the weight loss supplements and the muscle building supplements both prey on body image issues for young people, especially, or people of all ages. So that's why we bring them together. These products, though, even though they're available anywhere, including at your trusted pharmacy, they lack medical evidence to support their use. And they have been linked with eating disorders and steroid abuse. They can cause a wide range of health problems, some life-threatening, in fact, and I'm not overstating that. These kinds of products are so poorly regulated right now that they have been found again and again to be laced with illegal ingredients, prescription meds, anabolic steroids, excessive stimulants, sometimes heavy metals show up in these products. They're so weakly regulated that this is going on right now. If you went down to the store and bought some right now, sent it to a lab, who knows what you're going to find in it? Probably not what's on the package, and potentially some of these illegal prescription meds tainting the product. Now, they also worsen health inequities, and I'm going to tell you a little bit more about that. These products are deceptively marketed. They tend to not be too expensive, And the deceptive marketing is targeting communities of color and low-income communities, and certainly targeting by gender. We find that for weight loss supplements in particular, in African-American communities and Latinx communities, we see much higher rates of use than in white communities. And there is targeted deceptive marketing to these communities. We know in households, the lower income households have higher rates of use. In research with cisgender men and women, we see women having twice the risk of using these products as men, especially the weight loss ones. Here on the muscle building side, we see them more often used in men than women. And as I mentioned early on, we know there's higher rates in transgender and gender non-binary communities too. Education is a factor. And then in the most recent research that our group is doing on use of these products during the COVID-19 pandemic, we're seeing a 3 times more likely use by African Americans than white consumers, no doubt because of the predatory targeted marketing and deceptive marketing of these dangerous products. We have this up on our website. You could take a picture of that QR code, or we can share it with you later. So a few more slides and then I'll open it up for questions. Now this is part of our collaboration with ISL and also with lawmakers. So we have partnerships with ISL, with youth groups around the country, and with lawmakers in a number of states to be able to share with them, get their attention, the lawmakers, and talk to them about what we need them to do. We're advising them on, together, we're coming up with advice on legislation, amendments to satisfy diverse stakeholders. Now, it's very important that constituents be part of this, and that's youth are a very powerful voice in this issue. But no matter what kind of policy work you're doing, you want to have constituents of the lawmakers be part of it, community organizations, and people with lived experience. Now, here's a point. I gave you 3 other points about eating disorders. I want you to remember this one too. It is human nature. Constituent stories always are more moving and motivating than data. Now, that doesn't mean data is not important, but it does mean to get movement by policymakers, we've got to have the stories that lived experience communicated. Evidence can and should inform policy, but it is stories, human stories that can motivate policy change. And it's just human nature. It's human nature. It's the same for us as scientists. We're moved more by stories than data, but we also know how to read data. We got to have them both, the data from researchers and the stories from constituents and people with lived experience. So we've been, to make it really concrete, we've been working with lawmakers in Massachusetts, also New York, as Ryan mentioned, in California, and we're looking in other places to get a bill introduced to ban the sale of those products I mentioned, the over-the-counter diet pills and muscle building supplements, ban the sale to minors. The products are so dangerous, they're not medically recommended. It's a common sense place to start. So we've been working with Representative Kaycon in Massachusetts and Senator Mike Rush in Massachusetts to move this legislation forward. It's still legislation, not law yet, but there's a lot of movement happening now, and there's a way for you to get involved. And ISL has created just an incredible opportunities for young people, whether it's Massachusetts, you're in New York, California, New Jersey now, or other states, you can get involved in this policy translation in action through ISL. I have 2 slides here, both have QR codes. You could take a picture to get the URL or the QR code. This one is to a youth survey to tell us what you think about having these products preying on young people. If you're interested, take a picture, you can check out the youth survey led by ISL and a youth support letter. If this is an issue you care about and you want to sign on, you can see the youth support letter. You can take a picture of the QR here. And that the letter is for those who care about this issue and want to have your voice heard by lawmakers. It's a youth sign-on letter for youth anywhere in the country. So I just covered a lot. I'm going to stop there and see if we might have some questions for the next few minutes until the hour is up. Thank you for listening. And thank you also to folks who interrupted me early on to make sure I had my screen set up properly. I really appreciate that you did that so you could have the full benefit of my slides. So with that, I will stop sharing my screen. This last URL and QR code is to get to our economic report if you wanted to go back and see more of the detail about the data. So I'll stop sharing. Great.
Thank you so much. So we're going
Wonderful.
to be taking questions now. So John, if you want to take it away.
Could you go more in detail about how you calculated efficiency loss with regards to presentation?
Actually, that's a great question. And what I'd like to do is refer you to the report because we have a whole section on efficiency losses in there that describes the method, the sources for the method that we chose to do, and then how that was calculated. It's definitely in the report.
Oh, thank you.
All right, we'll take a question from Vanchita.
Hi, so thank you for that. That was a really great presentation. Since you addressed the topic of diet pills, I was wondering if there's like an economic analysis angle that sort of explores the connection between like the diet industry and eating disorders. So like the money that goes into this industry and the huge amount of money it generates, and that compared with the losses that we see through your study.
Yeah, excellent question. Right on the money, as they say, that question. There's a lot of work that actually you can find it in the business literature on how much money these industries make, because they're all reporting that to each other, what they're making. The weight loss supplements alone in the United States in 1 year is a $2.5 billion industry. That's billion with a B. That's only counting the US in only 1 year. Globally, much bigger industry. These products are all over the world. We're actually in the process of doing a global policy scan of what the regulation looks like in countries all over the world, because we know this industry is all over. Supplements in general are closer to $50 billion in the US in a single year. Globally, it's more like 250 billion, that's US dollars globally in that industry. The money coming in for marketing, all of that is huge. What we also, as another part of your question there, what we're also doing, we're just about to send out a new study for publication in a journal, hopefully it'll be out in the next 6 months, estimating the cost of eating disorders attributable to use of these products and the harm caused by these products. So we've got new work coming out on that. And then another study you might be interested in that we published a couple of years ago was a microsimulation modeling of if we had a tax on over-the-counter diet pills, what might a tax on diet pills do to use? So as you probably all know, cigarettes, tobacco is taxed in the US. That tax was added purposely to drive down use by consumers in general and youth, because youth tend to be more price sensitive because you just don't have as much money as, you know, a 50-year-old who's been working full time for a long time. So taxes are used as a public health tool, as a lever. We did a microsimulation model using standard methods from economics to estimate how much we could drive down use with a hypothetical 20% tax on diet pills. If you want to reach out to me later, I'm happy to share those other studies with you. Thanks for the great questions.
All right, we're gonna have Kushi, if you want to take it away.
So I would like to say that it's just great to see how research can actually lead to policy action, because one thing is that, you know, time and time again, research can say one thing, but that doesn't always lead to action. So it's quite nice to see that. But I wanted to ask what the distribution of the cost is. So you looked more at like total costs, but is there like, for the distribution of individuals with eating disorders, is there some percentage who have a very high cost, or is it more evenly distributed?
Yeah, great. I definitely would recommend that you check out our report too, because we have it broken down in much more detail. Okay. But yes, if you're looking at the individual level, people end up having to spend a lot more money for anorexia nervosa, because it's a very serious condition and can last for many years and can have more economic impacts on individuals. So individuals with anorexia nervosa and their families will be paying more than those with other eating disorders. However, when you then take a population perspective as opposed to the individual's perspective, it's the more common eating disorders that actually cost the economy the most. So that was a point I was making about binge eating disorder and the other kind of catch-all category. Even though it's got a terrible name that's obtuse, it's not that it's not a serious condition. It's not less serious than ones that got their own name. I just want to point that out. It's just peculiar with how psychiatrists name things. But it's very important to do what you're pointing out here. The cost to individuals is crucial information, but it's different than the cost to populations or the societal level. We want to know both. So thanks for asking that question.
All right, Tasmia, and then for now, you guys can take it away.
All right, thank you, Dr. Austin, for this amazing lecture, especially since it's such a significant topic that really needs to be heard, especially by youth. And I was thinking about the correlation between like poverty levels, especially in America, and how this actually affects eating disorders among youth and families, because I read some studies, including your paper in The Hill, how that there's barely any information in the CDC with guidelines about how to eliminate barriers to care. And how would you say is the best like policy to implement in order to prevent eating disorders from coming up in families that are struggling, like low income families, those who are experiencing poverty, since there's such a rise, especially with the pandemic?
Yeah, thank you. Thank you for that. And it's such an important issue that you're raising. And so few people know this. So I'm glad you're raising it now. During the pandemic, I'll take a step back to talk a little bit about this, how this arose during the pandemic. As you may have read in headlines, or maybe you're closer to it and have seen this happen, that food insecurity, as they call it, or nutrition insecurity, was a big issue, especially at the beginning of the pandemic. It already was an issue, and there's just terrible disparities or inequities across communities where we see before the pandemic, we had a lot more food insecurity affecting Black and brown communities, immigrant communities already, because even though the US is a wealthy nation, the food systems are not set up to make sure food is equitably accessible. Well, food insecurity causes enormous stress on families and on individuals, psychological stress, financial stress, physical stress. And then the pandemic escalated that. What we know from other research is that food insecurity increases the risk of developing an eating disorder. So with the pandemic, what was already a problem, not well recognized, just came right out into the fore. We see skyrocketing rates of eating disorders. We saw, especially in the first half of the pandemic, skyrocketing rates of food insecurity. Some of that has been addressed, but the underlying problems with our food system and the economic inequalities of access to nutritious food all month, not just at the beginning of the month, but when maybe some federal assistance is available, but we want people to have access to nutritious foods all month. That's going to be a problem after the pandemic. It's much worse, as Tasmia had pointed out, much worse during the pandemic. Now, you had asked for solutions. You raised a very complicated problem. I think one of the things we need is that the parts of our society, of advocates, of government folks who are focused on addressing our unequal food systems and food inequality, they need to be more educated about eating disorders and the mental health effects of living under those conditions. For the most part, they don't know anything. If you had a meeting with them and you said, hey, look, here's a study showing food insecurity is linked, that increases the risk of eating disorders, and then you have compounding mental health struggles on individuals and families, that would be news to them. They need to know that so that they can work in partnership. We could talk a long time more about that, but thank you for raising that question.
Thank you.
Hi, yeah, thank you so much for a great lecture again. I wanted to ask about how, if you've seen that in these other countries that are developing and countries that are, especially the ones that are suddenly rising and coming to these middle income brackets, for example, have you seen that these countries are also seeing a major increase in these eating disorders prevalence as their income level rises and potentially they become similar towards these Western countries? Are you seeing that this effect that we've looked at in the United States is something that's more global in these developing nations?
Yeah, thank you for that. We do see eating disorders around the globe, and we do see different rates, but we're also seeing increasing rates, as you pointed out. We see high rates of eating disorders in Asia, and that includes South Asia, Southeast Asia, East Asia, high rates in the Middle East. The eating disorder, someone had asked a question about distribution. The distribution from an epidemiologic perspective differs for some eating disorders and differs by gender in some of these, in the different cultural settings, where we're seeing more, like for instance, some of the newer research from Asia, including South Asia and East and Southeast Asia, we're seeing more similar rates of eating disorders in men and women, or boys and girls. I haven't seen research on transgender or gender non-binary in Asia yet, but I'm sure people are doing it. But we're seeing more gender equality than we have seen in the US or Western Europe. We're also seeing more binge eating in some areas, like in the Middle East, for instance. We're seeing a lot of binge eating disorder. So this is a mental health condition, and people need to have access to treatment. So yes, it's all over, and we need folks. There are folks working on the ground in many countries, and we need a lot more of that happening.
For sure. Thank you.
All right, thank you so much. So our final question will be Rayhan Opener. If you take it away.
Thank you so much for your lecture. I live in Australia, and I've heard so much about the Butterfly organization since it's such a prominent organization over here. And it's really amazing the impact and support the organization gives over here, especially for youth. And I was wondering, what steps do you think need to be taken in order to establish an organization like Butterfly in the US? And do you think Australia is so advanced comparably because of like the public perception of organizations such as Butterfly over here?
Ah, yeah, okay. So I'm glad you know all about Butterfly. They're tremendous. They're world leaders. So we do have organizations like that in the US, and we have the National Eating Disorders Association, we have the Eating Disorders Coalition, which is a federal advocacy group, and there's others, the Alliance. There's really excellent organizations. I think there's probably a couple reasons why the US was quite a bit behind, but that we did finally follow Australia's lead. One reason is there were just some incredible change makers with Butterfly who knew enough and had some access to funds to be able to make that study happen. They were people who were big thinkers, really effective at taking ideas that nobody else had thought of and translating it into the eating disorders community. So I want to give credit to the group of people who thought of it and made it happen. And that can happen anywhere, where you can have real visionary leaders step up, and then they change the game for everybody. And we're thankful to that. Another piece, though, is that the healthcare system in the US, if there was any one word that could describe it, I would say it is cacophony. It is such a chaotic system, so many different payers, so many different ways that people get covered. Depends on what city you're in, what state, whether it's rural, what condition you have, who the insurer is, how old you are. There's so many differences, and there's no central repository for the data. There is no one place, not like Australia, not like Canada, Western Europe, in different countries there where there's a central repository for health data or health systems data. The US is just chaos in terms of that. That made it a harder struggle to try to figure out how to do that. So we have it in the US, just the Australians, I think, were able to more efficiently move forward, to the credit of the folks who thought of it 10 years ago.
Thank you so much.
All right, thank you so much for everyone who was able to make it. And it's 1 p.m. So we really look forward to seeing many of you at the opening ceremony for Visathon, which is at 9 p.m. Eastern time, I believe. And we thank you so much for Kelly for putting this together. And we thank you for Dr. Austin for coming here, and for all hundreds of people from hundreds of different schools who were able to make it as well. So this was definitely an honor to put this together. It was really, really fun. Everyone enjoyed it. And there's like so many thank yous that are being pasted in the chat right now. You can take a look. So yeah. That's about it for today. And Durkash, you could take away for just the further information.
Thank you so much, Professor Austin. And there are a group of students who were interested in speaking to you further after today's lecture. So I'll open up the breakout rooms in just a moment, but I'd like to thank everyone for joining us today and for hearing Professor Austin's lecture. It was very informative, and we have a lot of very positive feedback. So thank you so much.
My pleasure.
Yeah. Thank you.
And also, the two research groups that are here, one of them is actually the ones who are leading. It's a specific group of students who are leading the work right now in not only reaching out to people in Massachusetts, California, with the youth survey that Alan and I have been directly distributing in the beginning of last semester, but also in terms of that, they want to actually compile a report, a student report on that, and to also build upon the infographic that I was able to make, and also with more data as well to present that with Stripe. And also the other group is actually working with the Nepal Child Health Institute, who their PI is actually the it was the pioneer of open heart surgery in all of Nepal. And he is leading a healthcare system in developing satellite facilities around Province 3 in Nepal to expand pediatric care in Nepal. So currently they're doing data visualizations and other financial work to see where these satellite facilities would be best allocated and best funded. So that's amazing work that these two groups are working on, and they would love to meet with you. And the breakout rooms are currently open.
So Ryan, should I go to the breakout room I've just been invited to?
Yep.
Okay.
Yeah, and
good.
I will be there as well to help manage it.
Great, thank you.